Okay, so in this chapter, we're going to provide an overview of platelet-rich fibrin. And what the goal here is to demonstrate how we can utilize platelet-rich fibrins for the different indications in dentistry. So it's going to cover gingival recessions, intrabony defects, extraction sockets, sinus grafting, GBR procedures, and we'll also cover new trends such as using PRF and Endodontics, using PRF for facial aesthetics, as well as some medical applications. So the goal of this actual video is not necessarily to provide all the data, of course, because that would take probably a full day to cover everything, but more importantly, just to kind of highlight where we're at in the field and also to present some of the nice and exciting videos that were provided by master clinicians in this textbook. So you'll see that in every single chapter, for example, GBR, we'll be describing how PRF's utilized in combination with bone grafts, etc. And then there'll be a nice video that demonstrates the whole procedure essentially and how they're utilizing PRF in those cases. And so you'll be able to screen over and watch some of these videos that will be provided in each of the chapters. So when we look at the overview, the first chapter deals with PRF and gingival recessions. And in these cases here, it's been really nice and interesting to see kind of the progress that's been made in this field since 2016 when we wrote the first textbook. And Dr. Allams deserves some credit here for the work that they've done where they've been able to take such cases and treat them with platelet-rich fibrin and lead to quite nice clinical outcomes here. Now, here's some more cases. Again, you can get a very nice outcome with some of these cases, but I want to talk about kind of where we're at in the literature. The way that this technique is done is that vestibular incisions are created, full thickness flap is raised, or tunneling, I should say. Tunneling is performed here, and the PRF is entered in here instead of obviously utilizing collagen. So that's quite nice, and again, nice aesthetic outcomes that are performed here by the group out in Los Angeles. Similarly, Dr. Zucchelli, an Italian colleague, has utilized platelet-rich fibrin. He uses a different approach. So here you can see here, there's a nice band of keratinized tissue. So we know very well, and I'm going to show the data, PRF has not been shown to enhance keratinized tissue width. So that's been known in the systematic reviews that were more recently performed. And in such cases, you require a band of keratinized tissue to do such procedures. But instead of performing coronally advanced flap alone, in such cases you can use platelet-rich fibrin, and this will lead to a very nice outcome. So you can see here Dr. Zucchelli takes very nice images, of course, and you can see a very nice outcome at the end. Now in 2016, we had looked at many different studies in a systematic review, and these are all randomized clinical studies where a split mouth was performed investigating Miller class 1 or 2 in all of the studies. And in them, coronally advanced flap was compared with or without platelet-rich fibrin, and you can see significant differences here. Emdogain versus PRF, no difference. Connective tissue graft versus PRF, no difference. Connective tissue graft versus PRF, no difference. Coronally advanced flap with PRF led to much better outcomes here of root coverage. Connective tissue graft versus PRF, no difference. So overall, like I said, it was very interesting to see all this data. But more recently, in 2020, I was able to finally do a very nice meta-analysis with one of my colleagues here from Brazil, Vittorio, and he and I performed this meta-analysis where we characterize where PRF is situated in the field. And we compared it to not just coronally advanced flap, but to connective tissue graft, emdogain, amniotic membranes, as well as connective tissue graft in combination with PRF. So when we review the data, you can see that there's been a number of studies that have looked at coronally advanced flap versus coronally advanced flap with PRF. And when you see it more to this side, it means it's favoring here PRF. So there's an advantage for root coverage that favors PRF. And statistically, you can say that if you use PRF in your coronally advanced flap procedures, you're going to get a little bit more root coverage, and that's been shown. So that's some nice data that's there. Now, when we compare PRF to connective tissue graft, we actually have a better result performed with connective tissue graft. And this is something that deserves a lot of attention, and it's very highlighted in the textbook. When you have starting baseline deficiencies in connective tissue width, PRF alone has not been shown successful to improve such cases. So it's very, very important, and it's highlighted in the textbook, to understand that when you have deficiencies in baseline keratinized tissue, you really need a connective tissue graft in those cases. When you compare PRF to Emdogain, there's no difference. When you compare PRF to amniotic membrane, PRF was better, but it was non-significant, so there wasn't enough papers to make this significant. When you add PRF to a connective tissue graft, you got better results here. Okay, so that's the data. Again, when we review this, of course, we can now say that PRF is better than coronally advanced flap. So we know that, and that's been known for some time. But as well, it's not a replacement by any means to connective tissue grafting, because when we do connective tissue grafting, we require this connective tissue graft to improve keratinization and keratinized tissue. And that cannot be achieved with PRF. So that's been well shown, and I highly recommend colleagues read through that chapters that are working in the field. Now, though some people will promote PRF for gingival grafting over Emdogain or amniotic membranes, there's been no data to support one versus the other. So that's still data that needs to be investigated, and probably more randomized clinical studies are needed on that topic. Again, if you do not have good baseline keratinized tissue, you need to utilize a connective tissue graft here. Now, one key that was quite interesting was that there has been some studies that have shown that if you use platelet-rich fibrin for palatal wound healing, when you take out gingival graft, for example, free gingival grafts or connective tissue grafts, one of the keys is that when you take out that graft, of course, there's a lot of morbidity there. You could take PRF, and because it improves soft tissue healing, you can actually pop it back into the palate, and that will improve healing thereafter. So that is quite interesting to see as well. We have had a great video and a contribution from Dr. Tuttle that is taking cases such as these and used them with PRF alone, and it's led to quite decent results. So I want to cover this case right here. These are the types of cases, like I said, sometimes patients come in and they just refuse to have connective tissue grafts because some of their friends have said it's been extremely painful, etc. And of course, it follows a strict protocol. So again, very, very similar to grafting procedures that people are aware of. But here you can see the first thing that's done here is that you're going to condition the root surface. So that's step number one. And then after this is done, of course, you're going to make some vestibular incisions. And then you can see after the vestibular incision has been created, you are then going to insert platelet-rich fibrin into these little tunnels. So here's a little video here. You can see platelet-rich fibrin is being entered. Okay, so there's these nice little videos. And of course, that's the first video. And it describes, like I said, you need to typically have at least 2 PRF membranes that are entered per pair of teeth. So you can see there's a lot of PRF that's utilized here. In a case like this, you might be inclined to draw 12 tubes of blood and then spin thereafter. And look at the final outcome. This is, like I said, a very nice case, and there was some quite pronounced recessions on either sides, especially for the canines. And you can really see an improvement that was achieved by following this type of technique. And Dr. Tuttle, like I said, look at the before. Look at the recessions that are here. And this is a case that was treated 3 years ago. And of course, then she decided to do, and the patient accepted to have either some crowns that were placed and really, really nice final aesthetic outcome here. And again, it goes to show you that, if you can follow some of these biological principles, you can achieve quite nice aesthetic outcomes with such cases. But as I mentioned, like I said, read the literature, read the chapter, really to know that PRF cannot be utilized for all cases. There's really a role for connective tissue grafting, of course, and but PRF can be utilized as a nice adjunct. One of the things that was mentioned in the book was there probably needs to be more research comparing PRF to collagen membranes to see if, maybe PRF can be utilized as a substitute from some of these collagen membranes, whether they be alloderm or other types of collagen membranes that are utilized on the market today. In summary, there's excellent data that supports its use for Miller class 1 and 2, especially when there's a baseline keratinized tissue. Where it failed in the studies was that it failed in keratinized tissue width, okay? And that's where the big thing was. In these cases where there was similar results to connective tissue grafting, it's very specific inclusion criteria. Anytime that the baseline keratinized tissue width is not adequate and you apply PRF there, you get a better result with connective tissue graft, okay? So be very much aware that it does not increase keratinized tissue, cannot be used for class 3. And again, this is the main thing here. When there's limited baseline keratinized tissue width, you must utilize a connective tissue graft. And that's what's highlighted in that chapter. When we talk about chapter 13, now we jump into the Intrabony defect field. This is the field that I enjoy working in the most. So I work as a clinician, and this is the main topic that I like to work with when I am in private practice. But I want to kind of review the literature. When we look at some of the studies that were done, such as this one here that was performed in San Antonio with Jane Chadwick as well as Professor Brian Mealy, they looked at the clinical and radiographic evaluation of DFDBA versus PRF for the treatment of intrabony defects. And in fact, it led to very similar outcomes. And so when you had these, narrow intrabony defects, what these colleagues were doing is that they were cutting up PRF. And of course, when you do this, make sure you take PRF from the bottom of the membranes, because that's where the cells are, as we've reviewed several times in the preclinical sections of this textbook. Place it in the intrabony defects, suture, and then afterwards, like I said, you can lead to very nice healing here. So that intrabony defect has been dramatically reduced here. And so many years ago, 5 years ago, when we wrote the systematic review, when we compared open flap debridement with or without PRF, PRF led to significant advantages in pocket depth reduction as well as clinical attachment level gain. Okay, and that was standard on almost every single study. We found the same thing. And when you compare DFDBA to PRF, okay, pocket depth reduction almost identical. Okay, 3.7, 3.67. Clinical attachment gain, exactly the same. So there was no difference. You gained 2.97 millimeters here in either of these treatment modalities. And that's one place where you can use PRF to basically save a little bit of money by not having to utilize necessarily DFDBA in such cases. And there's been a lot of studies, like I said, year after year. Look at all the studies in 2016. And many years ago, like I said, 5 years ago, it was really shown that PRF is quite effective for periodontal intrabony defect regeneration. Now, it is very much similar to connective tissue grafts. When these defects get so big, that's when you require bone grafting material. And we'll review the meta-analysis from 2020 that kind of support what you're going to do. In such cases, like I said, you need often a bone grafting material if the bone graft gets too big. These are some nice cases that were performed by Omid here, and he's done some really nice work by combining PRF with a bone grafting material. In this case here it was a xenograft, and he led to really nice outcomes here. So you can see here quite large intrabony defect, and one thing that was different in his case was that he's applying his technique, which is BioWAS with PRF here, as well as utilizing a connective tissue graft to try and maximize the regenerative potential here. And after surgery, he was, raising flaps to review the outcomes, and this was part of a clinical study. And you can really see here, this is real bone. I mean, this is bone that's been formed, and it's incorporated. And this is the starting X-ray, and look at afterwards. So you can really see improvements here, and you can really see that it's made bone. I mean, when you see some of his cases, it's very exciting to see some of these outcomes. And I've asked him to be a contributor, of course, because of his ability to perform such cases. There was value in having him contribute to the chapter of the textbook. Now, I've had the pleasure again to work with Vittorio on building the systematic reviews and meta-analysis. So when we review the literature, open flap debridement with or without platelet-rich fibrin, you can really see that PRF is really improving. So again, much, much better here. Now, when you compare a bone graft versus PRF, you notice that there's no difference between the groups. When you add PRF to the bone graft, there's a little bit of improvement by adding the PRF there, but it's non-significant here. So we cannot make that conclusion just yet, probably because some of these studies have not shown any advantage at all, okay? So that's just part of the literature. When we compare a barrier membrane to PRF, there's some advantage to PRF here, but it's not significant. No difference here between PRP and PRF in one study. No difference between Emdogain and PRF in one study. When you add PRF to Emdogain, there was no improvement. When you added metformin to PRF, there was a significant advantage. When you added bisphosphonates to PRF, there was a significant advantage. when you added statins to PRF, there was also a significant advantage. And that's where I think it's kind of exciting to see potentially in the future we can combine things like platelet-rich fibrin with some of these biomolecules, maybe statins, maybe bisphosphonates, maybe metformin, and lead to significant improvement. So that's one area that we said future research-wise, maybe you can use platelet-rich fibrin as a carrier system for maybe even antibiotics, et cetera, for some of these intrabony defects. Okay, so when we talk about periodontal treatments, one thing that's very interesting is all the work that's being done currently with lasers and non-surgical periodontal therapy. It's something that my supervisor, Anton Skulian here, has done a lot of work with, as well as with other colleagues. Here's Dr. Aoki, George Ramonos, Frank Schwartz, myself, and Raluca, looking at using lasers and photodynamic therapy for periodontal and peri-implant infections. Now, if you want to read some nice articles, like I said, on lasers themselves, I have a lot of respect for these two gentlemen. Of course, Tony was my supervisor, and he's one of the sectional editors of this textbook. But as well, Frank Schwartz really done some great work in this whole space. I'm not going to discuss this in this portion of this lecture, but again, if you want to read more, like I said, I highly recommend reading some of this topic. I just wanted to show kind of in these laser protocols, often after erbium YAGs are being utilized for the treatment of these peri-implant defects, the protocols are typically apply, the Nd:YAG at the very end and basically create a clot, because we know that having a blood clot is important for the stabilization of the clot necessarily and for regeneration of these intrabony defects. And many people have looked at that and said, well, why would you use a laser to make a clot when you can make a super clot, which is platelet-rich fibrin, and then essentially just tuck it in? So this is some work that was done by Dr. Fabrice Baudot, and he's from France, and he's one of the authors in this book. And he does this really nice protocol where, he's been able to just basically take platelet-rich fibrin and just tuck them in the pockets. So he basically just creates the superclot, which is platelet-rich fibrin, and you saw that he took it from the bottom. Remember that, right? When you got a full-size clot, take it from the bottom, and he just basically tucks it into the pockets using an instrument that you use for retraction cords, and away you go there. A lot of the times you do not need sutures, and this is this whole field of non-surgical periodontal therapy. It's these patients that come in with 5, 6, 7 millimeter pockets. What do you do with them? Do you go into surgery? Do you try and regenerate with lasers? Should you be using PRF and tucking them in the pockets? Should you be using Emdogain non-surgically? That field there is kind of one that a lot of periodontists are trying to do research and to try and advance the field a little bit. Okay, so that concludes the intrabony defects. We're going to jump now to extraction sockets. And there's been a lot of work here. Actually, some of the majority actually of studies early on looked at specifically this topic. So I want to jump into it and kind of talk about how this is utilized. Many people have utilized PRF alone, and you just basically extract the tooth and place PRF in there. It will make bone, and then within 3 months, like I said, you'll be able to place your implants. So one of the best studies, I think, to date on this topic was done by Dr. Pinto and Dr. Kurinen's group, and it was performed by Dr. Timmerman here. They looked at using PRF for socket management. So again, it was a split mouth study. On one side, they used the L-PRF, and on the other side, they had natural healing. And what they found was that they could limit how much bone loss would occur, and this in the test group, 22.84% versus 51.92%. Okay, so that's the width reduction. And there was obviously significant difference were found with the socket fill with mineralized bone. Okay, so that was a quite interesting study that was performed, and I liked the design of the study very much because they had a nice reference and points, and they measured at 1 millimeter, 3 millimeters, 5 millimeters, etc. Control versus the test group. Like I said, we lost 22% of the ridge, and then 50% in the controls. Now, one thing about the field of using PRF for extraction sockets is that there is a lot of variability in the literature. And so this has to be brought to the forefront as well, because some studies looked at the effect of PRF for the healing of extraction sockets. Again, very nicely performed randomized studies. And although the PRF group presented a smaller dimensional change in the height, this difference was only significant in the mesiodistal region. And the change here was 25% versus 22%. And there was no difference there. And so, sometimes I always say in the bone field, there's one study that shows positivity. There's another study that's kind of not showing any advantage there for the combination approach. This study here is a nice one as well, was performed in USA, in California. And they looked at advanced platelet-rich fibrin and freeze-dried bone allografts. And this was another randomized controlled study where they had 45 patients and they looked at PRF in one group, PRF plus the bone allograft, allograft alone, and then the blood clot. And when they looked at the bone mineral density of the area, it was highest in the allograft group, and it was actually lowest in the APRF group. And so by this study, there wasn't really a huge advantage in the bone mineral density between the clot and also APRF. Okay, so that's just the quality and the mineral density of the bone. But when we looked at, or when the authors looked at the vital bone versus the residual graft, you can really see that the majority of the vital bone was actually found significantly higher in the PRF group. Okay, so that was quite interesting to see. The most important finding from this study was the fact that when they looked at the ridge width and how much loss of the ridge was occurring, it was obviously highest in the blood clot group when compared to the APRF group. But when you actually combined it with the allograft, that's when you had less dimensional change. So again, this 1.8 millimeter of ridge width is probably very similar to the study that was done by Professor Kurinen's group, about 22%, but it could be better maintained if there was an allograft in there as well. And I think for the most part, like I said, most people will utilize allografts for extraction sockets, which I think is a standard with or without platelet-rich fibrin thereafter. This is a nice study that was done by Jonathan Dutoit, and he lives in South Africa. And in his study, he also looked at evaluating PRF alone in these extraction sites. So you can see it here. PRF is being placed in there, a little cross suture over top. Again, PRF can be left exposed in the oral cavity. And again, it will limit the dimensional changes. But when they actually looked at, the histomorphometric analysis in the split mouth study, there was no difference between the groups. So again, bone derived from PRF histologically did not differ from bone that healed without intervention. So the way that they did the study was that they actually isolated these bone cores and they compared the bone cores from natural healing, so test versus natural healing, and there was no difference in the histology that was observed. So that was one thing, like I said, sometimes you see a positive result with PRF when you use it alone, sometimes there's no difference. So it's always, in the perio field, in the soft tissue grafting field, you always see advantages typically. When you look at the bone field, you always see, this study showed it improved healing. This study showed no difference. And it's very, very back and forth. Okay, so typically, like I said, when somebody will say that PRF is very osteoinductive or PRF is really enhancing a lot of bone, those statements should be critically assessed, because when we look at the literature, like I said, and we looked at some very good studies, there is really variability there. And probably the field needs to further investigate this specific topic. More people, such as Jonathan Dutoit, since then have been combining PRF with a bone allograft, of course, or bone graft. I believe in this case here he was using synthetic bone material. But in any event, like I said, when you extract these teeth, a bone graft will really help limit the dimensional changes in these cases. Okay, so here you're going to add PRF with the bone grafting material. Where PRF can be utilized now is for the soft tissue healing. Okay, and in this case here, you can use PRF. That will work out very well, and then ridge has now been maintained, and you can then place your implant. Another colleague that has done a study while he was in UCLA is Alfonso Gil, and he did a nice study, again, teeth that are being extracted. Same thing, bone grafting material first with platelet-rich fibrin, and thereafter use PRF for the soft tissue healing. Again, PRF is very good for soft tissue healing. In these types of cases, like I said, you can use a collagen sponge over top. You can also use PTFE membranes. There's really no difference or no advantage for one versus the other. But again, when you use the platelet-rich fibrin, it's a nice, cheap alternative that can be utilized. And if you're going to use it for sticky bone, you can also use it here for the soft tissue healing. Okay, and that's just a case that was performed by him. Now, when it comes to third molars and extracting third molars, especially impacted molars, there's real advantages here to using platelet-rich fibrin. So this is a little different than normal extraction sockets, we're probably, if we're trying to do what's best for our patient, probably what's best is to use an allograft or an allograft in combination with platelet-rich fibrin for extraction sites. When it comes to third molars, probably what's best is to simply utilize platelet-rich fibrin as opposed to doing nothing. So we'll review some of these papers. One nice one that was performed in 2016, this study here looked at pain, number of analgesics taken, trismus and swelling in patients that were extracted third molars, impacted third molars. And what was found was that after day 1, 2, 3, and 7, they were all evaluated for all of these different criteria here, and there was a significant reduction in pain on days 1, 2, and 3, and in the number of analgesics taken on days 2 and 3 in the PRF group. Okay? So again, you will limit the amount of pain and most likely the amount of meds that that patient's going to take if you simply apply platelet-rich fibrin in those sites. This is another nice study, prevention of localized osteitis in mandibular third molars. The goal of this study here and the way that it was conducted is essentially PRF was placed in the mandibular third molars of 200 sites. So this was 100 consecutive patients. Again, on one side they placed PRF, on the other side they don't place PRF and they just let it heal naturally. In these cases here, the results here, the incidence of localized osteitis following removal of 200 lower third molars with simultaneous PRF placement was 1%. The group of patients whose mandibular third molars were not treated with PRF demonstrated 9.5% incidence. The latter group also required 6.5 hours of additional clinical time to manage LO. So when you look at this, like I said, there is some advantage to using platelet-rich fibrin here for the third molars. If the goal in dentistry is to always do what's best for your patient, most likely using, like I said, in a normal site, an allograft in combination with PRF, and then some kind of barrier over top, whether it be collagen membrane, whether it be PTFE, or whether it be platelet-rich fibrin for the soft tissue, is probably the standard. But for the third molars, like I said, just by taking one simple PRF clot and putting it in this site, you're probably going to reduce dry sockets, etc., in these third molars. And that's kind of a nice way to do it. And like I said, you don't need to compress. You know, I remember reading this study here. It was a quite nice one, and it's discussed in the textbook. You can just use one of the PRF membranes, just the full clot, and place it in the extraction socket. And a case like this that was done by one of my colleagues here, Dr. Senthil Selvan, he's also an author on the textbook from India. You know, these impacted molars that require maybe a little bit more surgery to remove them, and you have these types of defects that are created, you can easily just place a PRF membrane in there, okay, and then suture this up, and that will, you know, decrease the rate of dry sockets and complications, pain, and that's been shown in randomized studies there. Okay, so that's a nice way to go there. So in conclusion, it's an easy and simple technique here. It reduces early pain and inflammation in patients when utilized, and it's really, really good here for the soft tissue promotion, okay? And again, with the third molars, you can use it. The studies have shown up to 10-fold decreases here in localized osteitis. So interesting work there. Now, when it comes to PRF and implant dentistry, of course, this has become a very big topic now with these implants. What is the data that supports the use of implant dentistry? Well, when we look at all these previous work, we know now that PRF is going to improve soft tissue, and we also know that PRF is not so active on bone. So will colleagues find a lot of benefit by pre-coating the implant surfaces with PRF? The answer is no. There's really not a lot of data that supports that. Where it's very useful is for the soft tissue healing, like in all the other indications, and particularly around these immediate implants, where a lot of the times you place, let's say, a 5mm implant in a molar site, and you have all of these, you know, this open space for bacteria to go attach to the implants. That's where you can use PRF for the soft tissue healing, okay? And you'll see that in this chapter, in the sinus chapter, and in the GBR chapter. The master clinicians that are presented here, they're all using platelet-rich fibrin for the soft tissue wound healing. So we'll go over these different sections. Again, the way that it works, typically, people will use PRF here to improve the soft tissue healing. Okay, so I have to give a lot of credit here to Dr. Howard Gluckman. And Howie's done some fantastic work. He was the first author on the first version of the textbook, and of course we had to invite him back absolutely for this one because of the work that he's done in the field of implant dentistry with PRF. And I really like the way that he's working on these cases where, you know, he's aware that PRF is better for soft tissue when compared to bone, and he's using it in cases where you can use it here for the soft tissue healing. Okay, so here's a couple videos that are provided by him, and we're just going to go through them rather rapidly. So when we go through the video, and of course that's the beauty of this textbook, is that the videos are provided for the cases. I wanted to share this one here. Throughout the video, you know, it explains the process that he's going through, but when he wants to finalize here with his healing abutment, that's where the PRF is utilized there, and that's very, very important. The PRF is incorporated there, and that's basically for soft tissue healing. Always remember that PRF has all of those white blood cells, so the leukocytes, and so when you perform a procedure like this, the real advantage here is that all those white blood cells, all the leukocytes that fight infection are near the soft tissue. So on these immediate implants in particular, when those bacteria would love to just get in these pockets and attach to the roughened portion of that implant surface and begin periimplantitis, the PRF there has the advantage of A, having leukocytes that will fight the infection, as well as B, promote soft tissue healing and closure. So it'll actually create that soft tissue healing. So I really like the way that that's being demonstrated. If you want to watch the full video, like I said, that's available in the chapter on implant dentistry. And big thank you, of course, to Howie. Okay, so in this video here, one of the reasons why it's a really nice one, and I'm glad that it's included in the textbook, and again, I want to thank Dr. Gluckman for providing it. When you see this ridge split case with the implant placement, like I said, there was some bone graft, the sticky bone that was placed and utilized here because the GBR procedure was performed simultaneously. But of course, Dr. Gluckman realizes that, you know, there's advantages there with the handling properties, and that's why we're going to use the grafting materials in that way there. The reason why I like this video a lot is because the PRF membranes then, how are they utilized? It's an understanding that it's going to improve soft tissue healing, and for that reason, always collagen membrane first, and then second layer is going to be the platelet-rich fibrin. Platelet-rich fibrin here can be placed on the outer layer, simply because it's going to help with the soft tissue healing more. And again, when you're closing these flaps, if you ever have bacteria that are going to try and get into this area, or you're going to have some kind of infection, always remember that if there's platelet-rich fibrin that's laid down there, as the bacteria enter into that flap, they're going to run into not a collagen membrane where they can grow and proliferate, but instead a PRF membrane, and that's where the leukocytes are, and that's where you'll have an improvement in defense-fighting white blood cells. So again, this surgery, if you want to watch the whole thing, that's available in the implant chapter, and it's a very, very nice video that goes over the protocol. Other colleagues that have really done nice work, and of course the implant dentistry field, like I said, has a lot of colleagues around the world that are doing great work all over. I could have taken many, many cases here and discussed them from some of our co-authors. But this one here I liked a lot because it's a full arch case, it's fully guided. Like I said, when you go through the stress, let's say, of putting your patient through this large procedure where you're extracting teeth, placing implants immediately, on and on and on. Again, a case like this with Dr. Richard Martin, really using the PRF membranes here, laid out all over top after the grafting procedure. Why? To help with soft tissue healing. Then you can close up this flap, and you know now that you've had all the PRF that's there. Again, it's going to improve the soft tissue healing. If by any chance there's bacteria that are entering into these sites, they're going to run into platelet-rich fibrin. Of course, that's going to be a defense-fighting fibrin matrix that's going to block or prevent bacteria from infiltrating into the roughened portion of the implant surface. Okay, another case here by Dr. Bessa from Portugal. And a nice one here again, when you have such cases, like I said, that require extractions, and he's doing a lot of socket shield, and he provided a really nice case and an excellent clinician with nice images here, but you can see originally that there's a recession here. And one of the indication, and he's doing research on this topic, he's been utilizing PRF here for basically tucking it in to prevent these recessions or even to improve the recessions. Okay, so these are nice cases here. And like I said, if we go back on some of these slides and we look originally, look at where the initial is, and then look at the improvement that he's observed. Okay, so very, very nice outcome there. So really, in conclusion here, there's no data that really supports using platelet-rich fibrin for osseointegration. There has been some studies looking at ISQ, and there's small little improvements here, but the big bulk of top clinicians that utilize platelet-rich fibrin is mainly for its ability to help with soft tissue healing. Like I said, peri-implantitis is becoming an ever-growing challenge, and one of the things that we see more frequently is more and more people are going immediate. And when you go immediate, there's the risk that bacteria from the oral cavity have larger access to basically attach to the roughened portion of the implant. I always say that when bacteria attach to that roughened portion of the implant surfaces, that's when you've potentially started peri-implantitis, because the bacteria love to live on the roughened portion in particular. By utilizing PRF for the soft tissue, that's where you can create a little barrier, a nice little fibrin matrix. If it's got a lot of leukocytes inside of it, it'll further prevent these bacteria from entering the site. Okay, so again, utilize more favorably during immediate implant placement. You've seen a lot of these expert clinicians utilize it in a very nice fashion. Chapter 16, GBR. We've gotten a great contribution here in videos and also from content from Dr. Michael Picos, who's a close colleague of mine and also a close friend. And he's doing, in this case here, a very large augmentation procedure. And in such a case, it requires a lot of bone volume to be gained, both on the lingual as well as on the buccal, in this case here. And he's using, as much as possible, growth factors to help stimulate this bone. So instead of necessarily needing autogenous bone for such a large augmentation procedure, he's showing here how he's using growth factors, and this includes RhBMP2, so infused bone, with platelet-rich fibrin, which is going to help the angiogenic properties here, but mainly also for its handling. So this is a very complex defect to regenerate. It requires both grafting on the lingual and the buccal. And of course, for such cases, especially in older population, when you have access to these growth factors, like I said, there's obviously an advantage to it. We'll go through that case in the textbook. This is, of course, just a small little video that's demonstrating how he's utilizing platelet-rich fibrin along with RhBMP2 in this case here. So again, a really nice contribution from Dr. Picos without question in this textbook. One of the things that's very, very similar to the implant guys that have contributed. Just like with most colleagues that actually understand the biology, is you'll see here titanium has a risk of exposure. Of course, we know that. So he's placing a collagen membrane over top of the titanium to try and minimize exposure. But what do you do in cases like this when you want to improve soft tissue healing? The exact same thing as the other colleagues have shown. You take a PRF membrane, you place it over top, and that's where the closure is going to be. And I wanted to really show, look where that PRF membrane is being utilized, right where the flap is going to close. Again, if for whatever reason that flap is going to open, okay, you want to make sure that if the bacteria are going to come in there, they're not going to land on collagen or go into your titanium graft. Ideally, you want PRF there, because then if that bacteria goes in, it's going to hit the PRF, and of course, there's the leukocytes for you in the fibrin mesh. That's number one. Number two, of course, if it's going to help with soft tissue healing, you'll actually close this defect a little bit faster. Okay, so the soft tissue will heal a little bit faster there. Okay, so very nice case there. Here's another one that was performed with Dr. Gluckman again, down in South Africa. Again, very, very similar. You're going to see a very similar concept here. And like I said, it doesn't matter. It's amazing because you see these different colleagues from around the world in different places, and they're all using, in a very similar fashion, how they use platelet-rich fibrin. So again, here's a large grafting procedure that's being performed in the Curry plate technique. Okay, there's screws. Of course, Dr. Gluckman knows, he's placing his bone grafting material in here, and it's got better handling properties. It's much easier now to take, the sticky bone and insert it in such a fashion. He's doing the grafting procedure here. And then when he covers all this, he's going to use a collagen barrier membrane because he's going to follow natural GBR procedures. And if you want to do proper GBR, like I said, you're going to need that collagen over top. And then, much like the other cases, and much like the case that was just shown by Dr. Picos, what are they going to do over top of the collagen? Always, that's where the platelet-rich fibrin is going to go. And that's where the real advantage is, okay? It's very important that colleagues understand how these are done and the reason why they're done to improve the soft tissue healing. And this is where you can really lay down a few of these membranes here to really help facilitate the soft tissue healing. So again, I want to thank both of these colleagues for the videos, and the advantage, like I said, is that while you're reading the textbook, you'll be able to access some of these cases and the videos of the cases to see how these surgeries are actually performed. Okay, so now we're going to go over Chapter 17, which is going to cover sinus grafting. And this is, of course, an area where PRF is often utilized. So the first thing that I want to make a point to is that the width of the sinus is, of course, very, very important for using PRF alone versus using it with a bone grafting material. I'm not going to go specifically over all of the content here, but we've written a consensus report to figure out where you should use PRF alone versus when to use it with a grafting material. And it's very well covered in one of our consensus reports that was written with myself and Dr. Picos, and it has a lot to do with the width of the sinus. Okay, so that's all covered in the textbook. I'm just going to share, like I said, this is again a small little clip of the video that was produced by Dr. Michael Picos. In the majority of these cases, especially in the sinus, especially lateral approaches, these cases require a bone grafting material. So in the book, like I said, it's going to highlight when to do what. And there's some videos. So here you can see here, if there is a Schneiderian membrane tear, you can either use a collagen membrane here and use it with Dr. Picos' technique, sometimes with external fixation, and that's very well highlighted actually in his textbook. But in any event, what is the advantage of using PRF in such cases? Well, first of all, by doing so, PRF is going to be able to revascularize the area. So the sinus, of course, especially teeth that have been extracted many, many years ago, it undergoes a lot of remodeling. And of course, it doesn't hurt to have a little bit of vascularization that's incorporated in there. But more importantly, look at how much easier it is to handle this grafting material that's been produced via sticky bone type consistency. Okay, so here you can take the graft and now you can mix it with platelet-rich fibrin and do your augmentation procedure. And again, he's doing simultaneously a GBR procedure here, so of course it's a big case. when you're doing such cases, okay, the number one key thing here, just like in the GBR procedures and just like in the other procedures, when you go to close your flaps, okay, where do you want the PRF? Again, the membranes go on the outside for soft tissue wound healing. Okay, so it'll discuss, like I said in the chapter, and there'll be some videos, and it'll go over when to use PRF alone for sinus augmentation, when to mix it with a bone graft, how to utilize it, when you can use it alone for Schneiderian membrane repairs, when you should use a collagen membrane as opposed to PRF, and there's a lot of nice cases there. So these grafting procedures, like I said, whether they're lateral approaches, whether they're crestal approaches, they're all discussed. And you can see here, like I said, the use of this bone grafting material complex, that typically incorporates platelet-rich fibrin, which is cut up into small pieces and then mixed with a bone grafting material. And that's typically a 50-50 mix of cortical cancellous bone with a xenograft. And then, of course, the implants can go in simultaneously, and these procedures are then done. So if anybody wants to learn more, like I said, on any of these surgical techniques, I highly recommend assisting any of their courses. That can be Dr. Picos down in Florida or any of the other colleagues that have provided some of these videos. They've all done some great work here. Now, when it comes to these small little bumps via the crestal approach, this is a nice little case here where, if you need a few millimeters here, sometimes you can utilize platelet-rich fibrin. So if you just need a couple millimeters, this is a case that was performed by Dr. Yuri May, and he's more of a holistic dentist, so he does more natural things, and you can see the ceramic implant here. And of course, in that field, PRF is being utilized more and more frequently. And so in this case here, he's utilized platelet-rich fibrin while he's inserting the implant on the actual apex of it, simply to create a little dome, basically, to protect himself against a thin Schneiderian membrane. And then, of course, it led to a very nice outcome here. And a lot of people, like I said, will utilize platelet-rich fibrin just as a little protection/cushion as these implants are being inserted here. Okay. Chapter 18, we're going to cover here oral surgery. When we do oral surgery, the biggest indication where platelet-rich fibrin has more recently been studied is for osteonecrosis of the jaw. So you can see a couple cases here. This has really been kind of a growing concern for dentists. And when you see these cases, the main problem here is twofold. Number one, you got dead bone. Okay, so you got to revascularize that dead bone, remove it and revascularize the tissue. But you also have a soft tissue problem. Look at how much open soft tissue you have. And what is platelet-rich fibrin very good at? Soft tissue wound healing and revascularizing these tissues. So again, this has been well studied now. I remember in 2016, when we wrote our articles and systematic reviews, we said it'd be nice to see more data. Today, we've more recently looked systematically at all the papers, and you can see a lot of case series now with a lot of patients that are then being treated. And look at all the studies in 2016, 17, 18. More and more studies are coming out, many of them in 2019 now with 101 patients. There's been some nice studies that have really shown that PRF is very effective there. Other places that platelet-rich fibrin can be utilized as well as, many people are doing a lot of these grafting procedures where they're taking autogenous bone from the ramus, for example. In such cases, you can use the autogenous bone, of course, and mix it with platelet-rich fibrin, as is shown here from the Picos Institute. But more importantly, you'll see as well, before he does his grafting procedure, of course, he's got to close up that area where he's taking the autogenous bone. And in such cases, a lot of people will just close up and do nothing here and just let that heal spontaneously. Again, why not place a platelet-rich fibrin membrane in there? Okay, just allow it to heal maybe a little bit faster. So that's something that can be done as well. Okay, so here's a nice little video that's provided from the Picos Institute where they're literally just taking, following the harvesting of autogenous bone, they're placing PRF membranes in here. And in the textbook, like I said in chapter 18, there'll be an explanation for exactly why this is done and how it's done and the technique. So again, nice little pearl there from the Picos Institute. Chapter 19 focuses on PRF use in endodontics. A lot of people are surprised to know that there's actually a lot of work that's been done in this field. This is something that was done with Dr. Valerie Cantor, who's a professor at UCLA, and she's really done a lot of nice coursework, Did a lot of nice teaching on this topic. If anybody wants to learn, like I said, I can highly recommend some of the work that she does. And again, here, you can see the use of PRF in direct pulp capping. So if we look at this video here.
A specific concentration of ozone gas is then used over the pulp exposure to aid in disinfection and hemostasis. Liquid PRF is then flushed over the surface of the exposure. PRF has the ability to stimulate mineralization and mitigate the damage of LPS. The excess liquid PRF is evacuated with the microsection. Bioceramic putty is then packed over the pulp exposure, with the excess carefully removed with the microspoon and an additional layer added.
So there you can see the use of platelet-rich fibrin that's being utilized there in some of these pulp capping procedures. It's also used for different epexification procedures. So it's quite interesting to see its use, like I said, in endo. Here, sometimes they have to do some regenerative endo procedures where Dr. Canner, for such cases, when she goes and treats from the apex, these endo-treated teeth, will actually utilize a lot of the time platelet-rich fibrin alone for such defects. So here's a nice little case here, and you're going to see this video where she's going to use platelet-rich fibrin here alone for the treatment of such cases.
Membranes were placed as a grafting material. After 9 months, the patient returned for a recall appointment, and a limited CT scan was taken to evaluate the healing response. At the bottom of the screen, you see the original CT slice showing the largest extent of the lesion. On the top moving image, you can see the incredible heat.
So you can really see how this case was treated and what a nice outcome was achieved here by utilizing platelet-rich fibrin alone here. So again, there's a lot more work to do in the endo field before these become predictable, but it's quite interesting to see, its use, it's being more commonly utilized, and I think that field will simply continue. Now, Chapter 20 is dedicated to the use of platelet-rich fibrin in facial aesthetics, and of course, that's a huge topic, and it's also a very big market that a lot of dentists are starting to get involved in. I had the pleasure to co-author and co-edit a textbook with Catherine Davies, and she's a medical doctor, absolutely fantastic person to work with without question, and very knowledgeable in her field. And she's an aesthetic doctor, not a dentist, that just does a lot of these procedures in facial aesthetics for hair regeneration, etc. And of course, PRF is very highly utilized in that field. Like I said, that field is so big that a whole textbook can be written just on how to use PRF for different injection techniques, facial injections, how we can use the biofillers that we reviewed previously. So she kind of discusses all of that field. And like I said, if anybody's interested in this textbook, there's a lot of content in there for how to use it for facial rejuvenation with microneedling, vampire facial, injecting, hair regeneration, etc. And the field is quite straightforward. When we're used to, as dentists, to do injections in the oral cavity all day long, doing these injections extra-orally is a lot easier, so to speak. And as long as you have standard anatomy knowledge, these procedures can easily be adapted should your boards allow such procedures to be performed in your countries. So again, same thing, you're going to draw the blood, you're going to spin it, so you're going to remove the liquid platelet-rich fibrin, and then you're going to start by doing some of these injections. And amazingly, this was done by Dr. Paz at the White Clinic with Miguel Stanley, and I'll show the studies that were done, but this is actually a split face study. So they actually have done these studies where they draw a line on that person's face, where they do on one side one procedure, on the other side the other, and then they can really see what's working and what's not. It's amazing that some people would sign up for such studies, but they are being performed, like I said, with microneedling with platelet-rich fibrin, as well as using some different therapies in order to advance healing. So that chapter will focus a lot on those procedures. There's Dr. Paz and Dr. Stanley right there, and I want to thank them for their content. With platelet-rich fibrin, the one thing that's quite interesting is the fact that if you have acne, for instance, it's a real infection, right? It's an infection. It's tissues that are inflamed and infected. And if you think about it, if you can somehow deliver PRF into these infections, you might be able to improve healing. And a lot of people have started doing these acne treatments with microneedling with platelet-rich fibrin, and here after 3 therapies, look at the difference here. Okay, it's a substantial difference. So again, I always say, especially to young people, such as this one right here, this was treated by Dr. Ali Reza Panipur, a doctor in Beverly Hills. You can see this child has quite pronounced acne, and instead of putting all these kids and young people on Accutane and other drugs, like I said, it's quite straightforward to do these procedures. You pass a little microneedling device a few times, and you'd be surprised at how nice the results can be achieved totally naturally. There's not been a single chemical or drug placed into this young person's body. So again, I think that field there, and you can read more about it in this chapter, is quite interesting. Of course, Dr. Davies does a lot of work in the facial aesthetic field as well as for hair regeneration, and she uses now platelet-rich fibrin for those types of applications. Have a look at this case right here. It was done by Dr. Delbaccio, and he's somebody that I work with personally, so we've done this case together, where you can see some deep marionette lines, you can see some deep nasolabial folds, aging skin. And this was totally naturally done with lasers. So this was done with the Lightwalker Photona laser in combination with platelet-rich fibrin. And here you can use the BioHeat, so as a filling device, and it really leads to these nice aesthetic outcomes. And the real advantage from a marketing standpoint is the fact that it's totally natural. So both lasers, PRF, are 100% natural. And on top of that, there's very little overhead fees for you as a clinician when you're going to do some of these procedures. So that's quite an exciting field. The last chapter is on medical applications of PRF, and we've included this in the book just to show people how PRF is being utilized in many fields of medicine. And when you look at some of these cases, I mean, it's truly remarkable. This, of course, diabetes, these very big wounds that you see here. And the way that these are treated, of course, is platelet-rich fibrin is placed here. These were performed with the CPRF injections, so not the IPRF, but the CPRF, and more concentrated. And when you do such protocols, like I said, after 1 month, you'll start to see some healing. And this case resolved after 2.5 months. So again, it's really amazing how this can be achieved. And this was all done by a doctor that we're working very closely with, by Dr. Castro Pinto. So again, very nice cases. I've asked him if he was related to Dr. Nelson Pinto, because of course Dr. Nelson Pinto is doing the same thing, and I thought maybe it was just a family thing, that they're just really good wound healers, but in fact not related. But again, really nice cases that are being treated here. Look at this initial presentation. Okay, same thing. You can use platelet-rich fibrin, basically just tuck them in there, and then after 2 weeks, another application, 3 weeks, once per week, and by week number 6, like I said, that defects is now closed. That was a big cyst that was removed from somebody's abdomen in an obese patient, and when the cyst was removed, there was so much tension on the flap that they couldn't get proper closure, and it never healed. And by simply placing platelet-rich fibrin in there, again, that was done by Dr. Castro Pinto, really nice outcomes here. When we look at using PRF in orthopedic surgery, of course, this is done with CPRF here in horizontal centrifugation. So in many European countries, they've adapted in medicine the use of horizontal centrifugation. And a lot of people never went away from using horizontal centrifuges, first of all. But in these cases, like I said, they can use different types of ultrasounds, etc., to figure out where to do these knee injections. And the way that these are performed, like I said, is you will take the liquid CPRF here, and it's being injected into this joint space. Okay, so this is something that for all athletes, etc., or elderly people that are starting to have knee degeneration, knee pain, osteoarthritis is a big one. This is something that's commonly performed. We've done some animal studies in this field, so of course we've worked with different types of doctors looking at such potential here. And like I said, this chapter will highlight basically its use in different fields of medicine, which will be quite interesting to a lot of people. Like I said, a lot of people are doing this full time in their practices. The last thing, like I said, when you saw the Biograft, or those large PRF membranes, Again, here you see this big biograft. And the way that this is made, of course, is you can take this very, very big membrane here that's being produced, and if there's some kind of cancer, etc., you can then use this membrane and basically suture into it and basically use it as a soft tissue barrier to heal the different areas. So again, some nice work that was done here. Both the last video and this video were provided by colleagues that are working in Europe. So these are both performed in Denmark. And I want to thank Thomas Boas for providing some of these videos and some of his colleagues because again, it will enhance the understanding of how platelet-rich fibrin is working here. Okay, so this was done at the University of Copenhagen here at their general hospital. Here's another case, was done by one of my colleagues. Again, this right here was an actual melanoma. And this doctor, done in Naples, Florida, treated this graft with a autologous skin graft. So they took the skin graft, they placed it over top after they removed the melanoma, and in fact, this patient was asked to get an amputation, to amputate the toe. And the reason why is because there's low blood flow in toes, as you can imagine, but the patient didn't want to have her toe amputated, so she said, just go ahead, take a skin graft. They took it from her arm and placed it on her toe, and you can see here, the graft failed, and it was infected, there was low blood flow, and it didn't heal. And so before they amputated the toe, they reached out to us because this patient was looking for basically anything to do. And we created the biograft, and we used, in this case here, a non-stick gauze pad and just placed it there and just taped it up and changed this once per week. And sure enough, by adding the blood growth factors, it healed. Okay, so when you look at the before and then after, it actually healed. Okay, and that's as a result of platelet-rich fibrin. It's one of the reasons why I think, there's a lot of work that should be done in the medical space here. And probably in the next coming years, there'll be a lot more publications on such types of cases, diabetic ulcers, etc., evaluating the use of platelet-rich fibrin in medicine as well. So that concludes everything related to this overview chapter on platelet-rich fibrin. We've seen all of the different applications of PRF, so from extraction sockets, gingival grafting procedures, intrabony defects, all the way up to the GBR procedures and sinus grafting. So now the rest of the book, every chapter, all that you're going to see is basically expert clinicians that have provided their videos of exactly how they perform these procedures in clinical practice. So now as you read the rest of the textbook, you'll be able to watch these videos. Thank you.